Good morning, everyone, and thank you for joining. Dr. Evans, we're going to go ahead and kick off today's session at the top of the hour. Let's get started.
Well, good morning, everyone. I want to welcome everyone to our first ever Compass Network gathering. I'm just pleased that you could carve out some time in your schedule today. These are busy and exciting times, so I know everybody's busy, and we're all pretty distracted with all the things that are going on right now, but we have a great opportunity and just a great initiative for us to go forward with, and I'm happy that we got a chance to kind of talk about that a bit today. My name is Tom Evans. I'm the president and CEO of the Iowa Healthcare Collaborative, and you know, our organization has been involved in this hospital improvement work from the beginning. Our network continues to grow. We have worked with Iowa since 2012 and added South Dakota to our mix in 2016, and I'm so pleased to welcome the hospitals from Kansas and Mississippi to our network. I'm very excited about the engagement we're going to get and the opportunity we have to learn from each other as we all move forward. I want to give a bit of a personal disclaimer before we get going. I have seasonal allergies, and in the last week, these things have kicked up. So if I start coughing like crazy, I want you to know it's not COVID-19. So anyway, let's get moving. Again, my name is Tom Evans. And Kate Carpenter, who spoke with you just a moment ago, is our director of our hospital quality initiatives. We'll be kind of answering and responding to you as we go forward today. My history and a little bit about IHC. I'm a family physician by training. Was the chief medical officer for a larger health system in the early 2000s, and really became convinced that the providers need to be leading transformation in this time of healthcare reform and all that stuff. We convened in 2005 the Iowa Healthcare Collaborative as a provider-led performance improvement organization. So partnering with the Iowa Hospitals, excuse me, there it goes, Iowa Hospital Association, the Iowa Medical Society, we brought the docs and the hospitals together to drive change in Iowa. It started as an experiment and it worked. And we've been able to drive some pretty significant change, and we've been able to move that model into some other states. One of our partners, the Kansas Healthcare Collaborative, we worked very closely using this model to try to drive change in that state as well. And again, I'm welcoming South Dakota and Mississippi on our journey as we go forward. Kate has been with us throughout the HIN program. She is not only very well versed in this work, the core objectives of this program, but also in her understandings of how we move forward with CMS. So we're lucky to have her in a leadership position as we move forward here. The purpose of this is to really kind of kick off our discussion here. And I think I just want to underscore that the Iowa Healthcare Collaborative and our partner organizations in South Dakota and Kansas and Mississippi together will be known as the Compass Network. We together will be executing this hospital quality improvement contract. And I'm very proud to say that, you know, we applied, but there were only 9 organizations awarded the HQIC status. So we are one of only 9 organizations nationally that will be driving this work across the country. What are we going to do today? What I hope to do is to provide an overview of the HQIC program, kind of what are the big rocks, to describe and then to explore what's now, what's next, what do we do now? So we'll kind of go through those 3 pieces. So the focus is on patient safety, specifically with reducing harm, and then again, increasing care coordination and working to help people as they transition through care. So focusing specifically on high utilizers, how do we improve the effectiveness of the system through care transitions? The program, just like the HEN program and the HIN program, had a core group of initiatives that we focused on. And for those of you who have been through this, you will recognize many of the old familiar players here. So the core focuses of this program, there are 8 areas. Adverse drug events, specifically focusing, as we have from the very beginning, on opioid safety, anticoagulation, and glycemic management. The reason we focus on these is these are the three biggest areas of harm with medication use in the inpatient arena. So these are really important processes for us to get cleaned up, and there's a lot of harm we can reduce there. The program also focuses on antimicrobial stewardship, CAUTI, catheter-associated urinary tract infections, central line infections, C. diff, Clostridium difficile, pressure ulcers, readmissions, and sepsis and septic shock. Now, this is like we're just bringing the band again together. This is an old bunch that we've been working on for a while, but these are real opportunities for us to tune the fiddle. Now, CMS has also said, if you're working in a couple of other areas, we would love to work with you here as well. So falls, surgical site infection, and venous thromboembolism are all areas where if you have great work going on, you should continue that, and we can try to help you with that and report through that. It's also important to remember that falls, I believe surgical site infection and venous thromboembolism have all been in the past core focus areas. Those have now been moved to an optional category. So this is the guts of the program, the guts of the content that we'll be focusing on, but it isn't all. As we do each of these projects, CMS also has us focusing on some cross-cutting areas that go through each of these projects, no matter what the project is. If these are the whats, there are some hows that will be expected that we'll be tracking as well as we go forward. So what are these cross-cutting areas? Health equity, patient and family engagement, and a new one here, telehealth, are all areas that we will be kind of tracking. This will be how we execute venous thromboembolism or falls or whatever here. Each one of these, we'll be tracking these as well. Patient and family engagement, obviously a focus from the past. Health equity was added with the last program, and telehealth, with the changes that have been introduced through COVID-19, this is a key area for us to try to figure out how do we tune the fiddle and how do we do this differently. So who is the COMPASS network? Well, the Iowa Healthcare Collaborative is the prime contractor. IHC has the status with CMS that's called, we are an NQIC contractor. We have a certain status that allows us to contract directly with CMS. We are kind of the convener of this project, and now we have this contract working with our partners to execute this contract over the next 4 years. Together with our partners, we are the COMPASS network. Our network will be comprised of over 250 acute care hospitals, and we are focused in 4 state-based geographic regions: Iowa, South Dakota, Kansas, and Mississippi. And in each one of those regions, we'll be working with a state partner organization that will administrate the services locally and be working directly with the hospital. So for example, for Mississippi will be working directly with the Mississippi Hospital Association Foundation as kind of the lead partner there. In Kansas, it will be the Kansas Healthcare Collaborative working also closely with the Kansas Hospital Association. South Dakota, we will be working with SADAHO, and then in Iowa, IHC will serve as the lead. Geographically, this is kind of how we look. We're centered kind of in a north and south part in the middle center, in the centric portion of the United States. And it's interesting, we have an interesting mix also. KHC and IHC are organizations that kind of bring in both the hospital and the physician component to drive their services, where South Dakota and Mississippi are primarily hospital-centric. But I think we have a very rich base to learn from each other and to drive transformation. Another point I would make on this is this slide really depicts who would be the people responsible for having direct contact with our hospitals. But we have other partners. Case in point, in Iowa, we work very closely with the Iowa Hospital Association as our core data vendor, and they'll be working closely with South Dakota and Mississippi as well as we kind of process the information and go forward. In Kansas, the Kansas Healthcare Collaborative works very closely with the Kansas Hospital Association in driving services. So we're all in this together. Our hospital associations are key to our ability to drive these services, and we're thankful to have them as partners. So one of the questions you may want to be asking, because many of you will have the opportunity to kind of perhaps look at other folks, there are other vendors in your state. Why choose Compass? Well, the Compass network is designed to support rural hospitals and the vulnerable populations that they serve. In Iowa, we have 118 hospitals, but 82 of them are critical access. And the fact of the matter is, if you don't do rural in Iowa, you're not going to be able to deliver care. So we're very focused on how do we provide services in smaller markets and in markets that are more challenged for resources. Through our partnership with you and your participation, we will be providing guidance and local support to help you, the hospitals in these local areas, achieve the bold aims of this program. I want to underscore, though, this isn't just kind of sitting there and waiting for us to tell you what to do or to do stuff for you. This involves active partnership and participation. And we really are looking forward to working with you in helping you build the strategy for your community and helping you advance local sustainability. I think this is an important point. A couple pieces I want to make here is that we've been here from the beginning, from the beginning when CMS decided not to just invest in the QIOs, but to actually bring resources directly to hospitals to begin to drive transformation. The hospital engagement program started in 2012. IHC was one of the initial contractors, and we've been there from the very beginning. There were 29 initially. Then there was the second, and that was kind of a proof of concept program. The HEN program, the original HEN program, came out of the Innovation Center, and it was really kind of a, golly, can we work with hospitals and actually drive transformation? What we learned with the HEN program was a resounding yes. The hospitals can and will, because it's part of their mission, they will do this performance improvement work and this harm reduction work. So there was the HEN program, then the HEN 2.0 program, which is transitional program to the HEN program. We were awarded HEN 1, HEN 2, and we were awarded a HEN contract and now an HQIC contract. We've been there from the beginning when hospitals have been, where CMS has been working with hospitals. I think it's important also to note that in this process, CMS is always kind of ranking their participants to see how well they're doing. We were high performing HEN. We were high performing in HEN 2.0. We were high performing in the HEN program. And we are committed to being high performing in the HQIC program as well. You can see here, we are now at the beginning of that gray box, and we're going to be going through 2024 together. One other thing I would note on this little slide, you look at those dashed lines and you think, what is that? Well, the boxes are the pure contract period. The contract period went from such and such a date to such and such a date. And notice those dashed lines were periods where there was no program. The reason I asked my staff to include those is we made a commitment that at the end of the HEN program, we didn't just say to our hospitals, okay, we're done, see ya. We basically continued the program even though there was no funding, anticipating there would be future work. And the reason that's important is this work is too important to take your foot off the gas, and we don't do that. We will be with you as we go forward. I anticipate there will be a transition at the end of 2024 to something else, and we will be with you in that transition as we move forward as well. We're committed to this work. It's what we do. So there are 4 guiding themes, if you will, that I'd like to describe about how we do what we do. This is what we are as the Compass Network. Number 1, we're patient-centered. We really conduct network activities in a manner that is respectful of the patient's preferences, needs, and values, and responsive to those. We also really work to try to coach you in those skills and try to embed the way we say things and do things so that we're most responsive to the patient as we go forward. If we can't engage our patients as activated partners, we're not going to get there. The next thing is we are really committed to high reliability and developing a culture of safety. We expect us to have a culture of safety, but we expect you to develop a culture of safety as well. We provide effective and practical tools that promote high reliability, and the job is basically to produce consistency in quality and safety. But we're also committed. This isn't just about us in the inpatient arena anymore. We are only going to be successful if we can engage the entire healthcare continuum. So how do we engage inpatient, outpatient, long-term care, public health, community? Each one of us now will be operating in this new fabric of care delivery, and we're committed to reflect that as we advance our services. Strategic partnerships and collaboration. We really work to identify what your strengths are in the local community or in the state and build on those for the purposes of building synergy, but more importantly, sustainability. If we can't get this stuff in place and hardwire it, it's just a program. It's just a science project. We're about actually trying to change the way care is delivered. Now, the other piece of this is we want to maximize the value to the hospitals of the resources of this program. So again, maximizing the value and building local synergy and sustainability. Finally, I think it's important to remember that as a provider community, it's not just about us. So we really work to engage the hospital leadership, our local physicians, our patients and families, through the use of multidisciplinary teams to maximize the benefit to both the provider community, which is going to advance our sustainability, and to the patients we serve, which will advance their engagement and compliance. And actually, it's going to the rising tide will raise all boats. That's our philosophy. Now, a big piece that everybody probably has in the back of their mind right now is, okay, so what are we going to do on measurement and reporting? What stuff are you going to make us send in? And I wish I could tell you. The answer is it's in development. There are a couple of principles I can tell you about what it means to be in development at this point. The program is launched. We know we're going to have to measure progress across the core focus areas. If you're doing the optional areas, we'll need to have ways of measuring that. And I think we're going to have to be able to measure across those cross-cutting areas as well. My experience has been, and then CMS comes back and said, and then this. So point number one is that we're going to have broad measurements that kind of track our effectiveness as we go forward. That said, as we build our reporting system, we are committed to two particular points, design principles. A, we have to ensure that we're aligning with the meaningful measurement program and that the measurements that we are getting are meaningful. We don't want you to be gathering stuff that doesn't mean anything. So we want to really make sure that we're gathering stuff that is pithy, executable, and actually is illuminating. So we're really engaged with meaningful measurement. We're committed to meaningful measurement. The other piece that I can't underscore enough is that we're committed to reducing burden. You already have enough to do. I am very concerned with any of these programs that we end up spending so much time gathering data that we don't do anything with the data. So our experience has been reduce the burden as much as you possibly can so that you can target the resources to actually driving transformation and sustainability. Techniques that we use to do this, I mentioned the Iowa Hospital Association. We work with the Iowa Hospital Association data set, and we're going to be committed to use data from all kinds of places. If you've already reported it someplace else, we want to try to pull from that to populate our data sets as we go forward. So we want to try to not make you report a second time. If you've already reported it, we're going to try to find where we can get that data and use that to populate your data sets. Enough said on that. Basically, we're very concerned about reporting burden is key to us, and we're going to be working with the hospital associations. In Kansas, for example, the Kansas Hospital Association, how do we take what we've got and how do we use that to actually advance this program? Now, our plan for this measurement piece is in the design phase at this point. Once we get it kind of pulled together based on because we're going to get additional CMS feedback as we go forward here in the next couple of weeks. With that information, we'll be constructing our model, And then that model will have to be presented back to CMS for approval. So we will be able to release this to you after CMS says, yep, go forward. So that's kind of where things are at this point. So who can be a member of COMPASS? Well, we're focusing on the 4 states, Iowa, South Dakota, Kansas, and Mississippi. And if you're an eligible hospital in those states, you are invited to enroll. The eligibility criteria was not established by us, it was established by CMS. And literally there is a list of folks who are eligible. The criteria, this program is available to rural critical access hospitals, those serving vulnerable populations, or those who have been classified consistently as having 2-star rating or below quality measures. So if you need help, basically CMS has targeted these resources for the hospital work that we've been doing since the beginning. They have taken the resources and said, okay, now we're going to focus these on those who need it most. And that's the purpose of the program. How will you enroll? Well, basically, there are 3 parts to that. There is a COMPASS commitment charter. What does that mean? What a charter is basically a statement of mutual expectations. So the charter is, if I join COMPASS, this is what I'm going to expect from them. But by the same token, and it is also the things that I am committing to do to be a member of this network. So the charter is this joint commitment of participation, us to you and you to us, that we will do these certain things. With that, then there is a hospital profile, which will need to be filled out per facility, that helps us kind of understand who you are, what you have, and how do we best position services to be able to move forward with you. And then there's the BAA form, the business associate agreement, which basically is saying we will protect the data that you send us, and you will protect the data that we send you. So it is, as a business partner, we're going to be good partners for each other. And this information can be found on our website, which is on this slide, which I'm sure is going to be distributed. This presentation will be distributed later. So what's next? Well, we just got this information less than a week ago, and here we are. I think what you need to do at this point is we need to make sure that your enrollment is complete. It's interesting that in the first 6 months of the program, we're to recruit up to our contracted level. COMPASS is, we kind of started this ahead of time, and I'm proud to report that we're over 70% of the way recruited already. So we want to make sure that your enrollment process has been completed. Those steps that I described before have been done. And then because we're so far along on our recruitment, we're actually going to get busy. So our next steps, we're going to be beginning it in October, and there's a document that you're going to be receiving called the Next Steps document, which is going to be, it's going to have program contact information. We're going to be assigning quality improvement advisors to each hospital. There is going to be a getting started checklist as we're kind of, getting everything ready to go. And then we're going to begin to bring to you whatever we know with regard to the reporting and the measurement as we go forward. So stay tuned, get your enrollment done, and then let's get ready to move in October. This is a list of key contacts, and I want to both illuminate this and kind of introduce these people to you, but I also want to personally thank these people who have been leads for each organization. Kate Carpenter, who's going to be talking to you in a moment here. Kate has been just instrumental in not only the application, but also the coordination of the different states, and I'm just thankful she's there. Kristen, I've worked with Kristen through the HIN program, and she's been a strong leader in South Dakota. Michelle Clark, I've worked with her in the past in Kansas, and I'm excited to have Kansas joining us. And I'm particularly excited about our newest partner, the Mississippi Hospital Association Foundation and the Mississippi Hospitals. Linnell Weems is going to be the director for that. And I'm really looking forward to advancing work with Mississippi. Just for Linnell, and I assume you're on the call here, but I have a brother who's a cardiologist who just moved to Mississippi. So I'm very excited about working with Mississippi as well. I now have a family connection. So this is kind of the last slide here. I've raised the flag or waved the flag about Kate a couple of times here, but and if you have questions, don't call me, call Kate. But and that's the point I'm making here is that Kate is the person with all the answers, and I'm going to turn it back over to her now to kind of lead us through our questions section. So Kate, back to you.
Thanks a lot, Tom. I want to start by just thanking everybody for taking the time to attend this session today. Our team has been working over the past several months in preparation for this program, and I know we're ecstatic to see this kickoff call come together to get today and see so many, 318 of you, in fact, on the line, excited to hear what's next. I appreciate many of you have been chatting in questions throughout the session. So I think there's 4 or 5 questions we've received throughout the last half hour. We'll start by answering those. While we facilitate that Q&A, I'd encourage you, if you have a question, go ahead and enter that either through the question and answer function of Zoom, or feel free to chat that in either to just the panelist group or attendees, either or. We'd be happy to answer your questions. Of course, it's a new program, so there are things we don't know and are learning every day. So if it's a question we can't answer today, our commitment is to find that answer and get back to you following today's session. The first question that we had come in is a simple one, but it's asking if the slides from today's presentation will be available to attendees. And the answer to that is yes, absolutely. Lexi Hudacek, who's our project support specialist for the HQIC program, will be editing this video and sending all registered attendees a link with the recording for today, and also a PDF version, handout version of the PowerPoint, so you can have that for your reference. So thanks for that question. The second question we received is, are critical access hospitals eligible for this program? So thanks, Carla, for that question. And the answer is yes, absolutely, and are strongly encouraged to join. In fact, I think one of the really unique things about the HQIC program is it has been designed this time specifically in tune to the needs of small or rural critical access hospitals. And so I think that there's a lot of opportunity in this next program period to help meet needs and requests that are specific to critical access hospitals. So thanks for that question, Carla.
Kate,
yeah, go ahead, Tom.
I want to underscore that one for a second. You know, a lot of the programming in the past has been focused on all hospitals, and our feeling has been it's almost been like critical access hospitals in some ways are almost have felt left out. And I want to underscore what Kate said. This program's literally been designed for you, so this would be an emphatic yes. But I want to also underscore one of the things that's a nature of the smaller hospitals and the critical access hospitals. While we don't have the resources that the larger facilities do, we are more nimble. We know our people. We know our communities. And I just want to underscore that we can do this. And if anybody can respond nimbly to how change can be made, my experience has been it's the smaller hospitals that actually can navigate the curve more quickly. So the answer to this one is an emphatic yes. And let's go show them what we can do.
Absolutely. The next question that came in is, can we review again who the 4 states are in the new Compass network? The 4 states that we have partnered together to form this rural powerhouse of a network is Iowa, South Dakota, Kansas, and Mississippi. And I'll just add to that that these partners were picked very strategically and with a lot of intention. We're excited about these 4 partnerships. We know that the leaders in these states are committed to this program, and we're excited to have Kansas and Mississippi hospitals joining our network for the next program period. So we want to send a special welcome to them on the call today. The next question is, when does enrollment need to be completed? So thanks for that question. Many of you who are on the call today, I want to just acknowledge, have already completed the enrollment process. We launched enrollment, I think it was the first week of August. We've got over 180 hospitals already through the 3-part enrollment process. And so, Michelle, we did just encourage you to complete enrollment as soon as possible. And then we'll have a member of our team help follow up with you to assist you with the process. The next question is, does this mean that we can stop reporting measures from the HIN program? That's a great question. Thanks for sending it in. Tom had mentioned that in October we'll be sending you a letter with getting started materials. In that letter, it'll sort of describe for you how we're going to plan to approach the measurement transition. Many of you, and Tom sort of indicated this during his presentation as well, when programs stop, we don't stop, because we're here serving patients every day, and it is critical that we're always continuing to drive and improve quality and safety, regardless of whether there's a program or not. And I know that that is important to all of you as well. So many of you are still reporting HIN program measures. I would just say continue to do what you're doing currently, and we'll be reaching out to you in the next couple weeks with additional information on how we'll be transitioning reporting for the next program. Thanks for that question. The next question has to do with core areas of focus for the HQIC program. The question is, do you have to participate in every core measure to be a part of the program? CMS does really encourage hospitals who are committed to this work to consider within each of those 8 focus area domains how they can drive safety and quality. What I'll say is, and we'd be happy to follow up with you individually to address any concerns, but our network is, I think, uniquely, when you look across national networks, uniquely committed to leveraging existing data sets and sources to help satisfy the reporting requirements for this program. And I can tell you that leaders from our 4-state network have been convening regularly over the course of the last 2 months to really examine measurement and identify areas where we can eliminate self-reporting. We can use claims. We can use your NHSN data. We've learned that we're going to also have access to QualityNet data to help satisfy some of the reporting requirements for this program. So the short answer is yes, but I would just encourage you that in a lot of those areas, we'll have the data. It won't require extra reporting on your behalf. I'm seeing those are the questions we started with, but I've seen some others come in. Let me get a chance to catch up here. There was a question regarding the additional areas of focus and how many of those you needed to participate in. In the network charter, it does outline that you would be willing to participate in at least 2 of the 3 optional focus areas. What I can tell you again is that a lot of our claims and NHSN data does help satisfy some of the reporting requirements in those areas, but we also understand some of you are smaller facilities and may not be doing, for instance, a large volume of surgical procedures. So there's some areas where you won't be eligible to report, but we would encourage you to take a look at your organization's strategic plans and your organization's goals for safety and quality and see where they align and where we can partner together to help support resources and tools in those areas, and that our network as a whole is committed. Your clinical improvement consultant will work with you to help customize a plan that fits your organization's needs. Let's see. To make sure that I don't miss any questions here. There is a question coming through the chat regarding If hospitals who are outside of our 4-state network can participate in the program, one uniqueness of the CMS program, and this doesn't just apply to Compass, but it applies to any of the 9 awardees, they have specified and sort of prescribed our network size. So we have to be within 200 to 300 hospitals is where they've capped every network off. So if you're on the call today and outside of our 4-state region, I'd encourage you to reach out to myself or your state's key contact for additional information. And if possible, we'd love to have a discussion on if we can bring you onto the network as a participant.
Hey, let me jump in on that one a little bit. Kind of the long and the short of that is, can we have people outside of the network? Yes, but we are going to be capped at a certain network size. And so we are offering kind of first seats to Iowa, South Dakota, Kansas, and Mississippi. We would, however, we are willing to consider others depending on the situation. And if you have a weird situation and you want to present it to us, contact Kate and we'll certainly take a look at it.
Thanks, Tom. And then I'm seeing an additional question come in regards to NHSN reporting. And Don, you're right. As with the HIN program, many of those hacks and infection-based measures are reported through NHSN, and we'll be maximizing the use of that reporting to help satisfy some of the reporting requirements. There are many elements across CAUTI, CLABSI, C. diff, et cetera, that we'll be pulling directly from NHSN. And as our measure set is finalized, we'll be happy to provide specific numbers of the elements that we'll be pulling from each source.
Basically, if you've already reported it, we're going to try to use it.
I see a question that has just come in regarding if there's funding opportunities or grants available for any additional resources that organizations might need. That's a great question. Oftentimes, and through each of our states' Office of Rural Health, sometimes there are additional funding opportunities available to hospitals. I know that the Compass Network and also the local hospital associations do try and illuminate those opportunities when they become available and make sure we communicate them outward to hospitals as we find those opportunities where we think there might be supporting resources. Okay, Tom, so with that, I think we've concluded our question and answer session. I'll go ahead and kick it back to you to close us out.
Well, I really appreciate, again, everybody carving out some time to kind of help us get together for the first time and try to figure out what this means to be us and how do we go forward. I'm very excited. I've been looking forward to this work coming down the road, but I would leave you with a point here that, you know, we've been doing this since 2012, and that's great. And in this program, even the HQIC program was designed, you know, last year. And now we're in a completely different time. COVID, I mean, a worldwide pandemic has hit us and we're distracted and we've got all kinds of things transitioning around us. Is this still the right thing to do? And I would underscore that it's never been more the right thing to do. This underscores what we should be doing even more. We've been trying to drive transformation of healthcare together for, you know, probably 10 to 15 years here. But what's happened is with the COVID pandemic, it's underscored the inadequacies and the inequities of the system. And we have never had a time when the system is as receptive to transformation than we have now. And I personally believe that it's the provider's opportunity to step up and to actually describe what good care is and actually put the new systems in place and the new processes in place that will deliver better care, higher quality, safer care in a sustainable manner. So we've got work to do. I'm very excited to be with you in that journey. Forget COVID. Let's just get to work on improving the system. Thanks, everybody. We're so glad you're here and looking forward to working with you over the next 4 years. Thanks a lot.